I'm Lisa McDowell with Norellis, and I wanted to introduce you to Dr. Sankar, who's a pediatric neurologist at UCLA. Many of you already know him, but you are in excellent hands here to listen to what Dr. Sankar has to say. He has just recently resigned from being the chief of pediatric neurology, but he is still practicing and traveling diligently. And with that said, thank you all for being here, and turn it over to Dr. Sankar.
Okay. Good morning, and thank you all for joining us. I just wanted to let you know that as much as I'm trying to slow down, I actually have in-person clinic this afternoon in Westwood. So I'm going to rush out after this talk, but I'll be here tomorrow if we didn't get to all your questions. Tomorrow I would have a lot of flexibility with time. You'll see me hanging around other than my lecture. We may cover some of this tomorrow again because that lecture has rescue also, okay? But don't think of me as being rude if I run out in a hurry because I need to deal with traffic and get to clinic this afternoon. So this particular one is to introduce you. This is a more focused talk on this preparation called Valtoco. And for those of you who have used seizure rescue medication, the important thing to recognize is it's the same active ingredient that you have already been using for 20 years. I think many of you are familiar with the diazepam rectal gel, right? This is the same medication, but a whole lot easier to use, okay? So the slide wants you to give the disclaimer that during any discussion, I'll try to finish in time to leave you some time, but don't ask specific things about a patient, such as your family member. This is not medical advice, but information, okay? We're not doing consultations in this fashion. So it needs to be very general, okay? And so what is Valtoco? Valtoco, as I told you, is diazepam. It's used for quickly putting out a seizure, okay? Because of the way studies get done and medications get approved, when they are designed for rescue, you will find that everywhere you go to one of these talks and see the slides, they keep mentioning seizure clusters. That is because the testing is done by seeing what's the recurrence rate, okay? But in reality, if you want to interpret this as treating an acute seizure event, you are correct. We by no means imply that when your child or family member is seizing, you just let it go because it's not a cluster yet. You understand that, right? So don't get confused by this language of clusters over and over, okay? It is to terminate a seizure, all right? So the device, there are going to be further slides showing you how you use it. So we're going to talk a little bit about frequent seizure episodes, and then about managing them, having a plan, and about the product and some patient resources from the company, from the Valtoco website. All right? So episodes of, again, as I told you, they will keep focusing on frequent seizures, but I think for a lot of my patients, just seizures, right? You really don't say, oh, I have to wait for a cluster, till 3 seizures occur. No. Really, people sometimes have uncontrolled seizures despite what the clinician and the family thinks is adequate treatment. Meaning, we want medications that are maintenance medications at a level that's tolerable, where people can function, right? And sometimes that is sufficient to control the seizures most of the time, but there could be a viral infection. There could be in some cases, a hormonal cycling like menstrual period, right? There may be circumstances, occasionally my patients just run out of medication on day 30 and the pharmacist won't give them the medicine until the next day. So for a number of reasons, that you can have an unexpected unforeseen seizure event. And when that occurs, if two or more occur within the same day, they call them cluster seizures, right? And so they can happen either in focal, or what they used to call partial epilepsy, or in generalized, any kind of seizure episode when it becomes unexpected and uncontrolled. Doesn't stop on its own, right? That's an emergency that you want to deal with. So it can occur in children, adolescents, adults, elderly, can occur at any age, right? And they are common enough that there are, in fact, 3.5 million people with epilepsy in the States. Probably somewhere between 150 to 200,000 probably experience episodes of unexpected seizures. And so they can be unpredictable, they can still happen, and of course the rescue medication allows you the earliest possible treatment. The key issue is the advent of rescue therapies 20 years ago made a dramatic difference for families because it allows you to handle a lot of these things without going to the emergency department. Those of you who have been to community hospital emergency departments already know they're not seizure experts. Sometimes they'll say, oh, let's get a CAT scan, which is really, we don't need a CAT scan on somebody with established epilepsy and a neurologist, right? We know these things happen. So the whole idea is to accelerate treatment so that the treatment can be done at home safely. The word safely is also to be interpreted this way. It is actually safer in your hand than in an emergency department doctor's hand, mainly because of the time factor. You see, you can address this in 5 minutes. But to get to the emergency room, the average travel time to treatment you can see in the slide. And what happens with seizures is that the longer they go on, the less responsive they are to these medications. So when you go to the emergency department and they give something like an IV injection, it is the same class of medication. If they use things like lorazepam, right, or diazepam, it's the same type of thing. But these things work best early in the course of seizures. Which means when you get this in the emergency department, the dose may be higher than what works at home. And if it is so high that the patient is not breathing right, they're not going to come home. They're going to get admitted to the hospital. Understood? So you can avoid a lot of hassle by making sure that you have rescue therapy, and you can ask for it if your physician hasn't already opened this topic, because these are things you don't need a whole workup if you already know your child has epilepsy and why, and okay? So rescue medicine basically allows you to take control, and so the managing the episode involves Valtoco. Here's a dispenser. It is very similar to many products that are used by a nasal spray, including migraine medications. And every person should have a seizure plan. You see in the illustration a typical paperwork. Now, being a pediatric neurologist, a lot of my kids do because the schools insist that you have an action plan, right? For others, it may be useful also to think about what to do, including if your child is going to be at some relative's house, right? Grandparents' house. And the action plan form can be downloaded from the Epilepsy Foundation or a variety of sources, right? And so you can develop a plan, you can update it as necessary. The plan may indicate to, for instance, the school when this should be used, how it should be used. Generally, school nurses and affiliates are pretty good at doing rescue therapy, because it'll be difficult to be a teacher and not encounter management of acute seizures in an epilepsy patient. All right? So this is how you use it. This looks like a very complicated thing because it has a multi-illustrated panel, but it's actually not that complicated. I'm going to show you without going through this very complicated thing. This end goes into the nose. These are the two fingers with which you hold. This is for your thumb to squeeze. Okay, it's that simple. Stick that thing in the nose piece in the nose and squeeze. And so that's what it is, and it is diazepam, same medication as in the rectal gel, and minimal side effect. And actually, change in taste or a nosebleed, if you live in California, you have dealt with nosebleeds already because we live in a pretty dry country. Nobody can prove that diazepam causes nosebleeds. It's just one of those things. But in general, change of taste, none of these actually matter if you're actually seizing, right? So those are things you may sometimes hear from volunteers, but they really don't matter. And here the dosing is shown. It comes in 5 or 10, and then the 15 and 20 are provided in 2 devices. Understood? So if your child's dose is 5, you get 1. 10, you get 1. If it's 15, you get 2 7.5s. And for 20, you get basically 2 10s. So if you're using 5 or 10, 1 nostril. When you have your dose comes in 2, one nostril each. So very, very easy. Okay? And then everything you need to give a full dose is in a blister pack. So the blister pack for the 15 and 20 will actually have 2 units as shown in this picture. So what's the most important thing I want to tell you is here's the instruction for use. It shows you stepwise what I told you, which is fairly obvious, right? Take it out of the pack. It shows you how you hold it and the plunger, and then stick that in the nose and squeeze. What it doesn't tell you, and I'm going to tell you, is don't try to make sure it works by throwing it in the air and squeezing it to make sure. Don't do that, because there is only 1 dose, right? We can assure you that it's foolproof, it works every time. But you need to squeeze the trigger only when the probe is in the nose. Never try it in the air just to make sure it works. Because it's not like your decongestant spray. It's not a multi-dose thing. There's exactly 1 dose. Okay? Couple of things people ask me sometimes is, can I use it when they're actively seizing? What if they can't inhale? 2 things. Yes, you may use it when they are seizing. Secondly, inhalation is not involved. This is not a therapy that works in your lungs. This is like a topical application to the mucosal membranes in the nose. So when you spray, the particle size is sufficient that it will deposit around the nasal mucosa. In order to breathe it in, it has to be a lot smaller. Understood? So it's not lung medicine, it's just mucous membrane medicine. Very fast absorption, doesn't even have to go through the liver from here, can go straight to the brain and works very, very rapidly. Okay? So the reliable benefits are it can be administered by anyone, not very technical, right? As long as you don't fumble getting it out of the foil pack, right? And the dosing can be determined in the clinic. What's the right dose? We usually have formulas, and I always tell people you're going to round up then down because there's a lot of safety margin, okay? And in a given day, if necessary, your doctor will go over your child's or family members' dosing with you. I don't want to focus on it too much other than telling you It's possible after 4 to 6 hours to repeat a dose if necessary. But many people, the vast majority of people, need only one to keep them going well for the remainder of the day. Okay? And there are resources for you from the website, right? It's available at all retail pharmacies. It's got pretty good coverage. Your copay for those who have that kind of insurance should be very low. For those who are on, California Children's Services, there's no copay, as you know. Okay? There are demo kits and training devices. I keep thinking they are probably not necessary. I really don't think you need to have complicated training to, squeeze that with your thumb. But they are available. Especially if you're trying to show your grandparents how to do this. Something like that. Okay? So that's, there are personalized things. There are support from, you can go to My Neurelis website, and you can also, we have our rep here. If you need any further information regarding coverage, etc., my experience is it's covered well. I think everybody understands that they would rather pay for this than pay for an emergency room visit. And I think many of you should also recognize, now that we are barely coming out of a pandemic, we know and we have jumped from the pandemic to a current epidemic of respiratory viruses. So most hospital emergency departments are overrun. It's the last place you want to be. Okay? So if you don't have rescue yet, you should talk to your epileptologist, neurologist, primary care, right? To get you some of this. Okay? I am going to kind of leave these slides now and just open it up so you have some questions. The safety informations are much more for the doctors than you. Most of the safety information pertain to the fact they are no different than the rectal gel if you're used to. That is, these class of medications can interact with opiates. The FDA always wants us to talk about it. In reality, none of my patients are on opiates, and I don't know if anybody in this room has a family member with epilepsy who's taking regular opiates. It's a highly uncommon situation. But opiates are a sensitive topic in this country, as you know, right? Politicians are talking about it, so it creeps into it. That those who are in opiates, these drugs will interact to prolong CNS depression, increase the risk of respiratory depression. The other thing is, if you're using it all the time, you can get some dependence on it. So we have to limit how much you use. Generally, you should not be going through, if you are in good hands, maybe you use once every 3 months. If you're really lucky, you had a very meticulous doctor who gave it to you, but you've gone through 2 years without using it. But it is still good to have, particularly when you travel, right? A lot of those situations. However, if you're using it, consistently 2-3 times a week, maybe the maintenance therapy needs to be better. So that's something you would talk to your doctor about. All right? So I'm going to stop there, and that leaves us a little bit time for your questions. Any questions?
Yeah. So thank you for clarifying the cluster seizure part, because I was very confused about that.
I think everybody is. The funny thing is, I never bring up the issue of cluster to my patients. I just tell them if your child has a seizure.
Right.
The problem is, you see, they cannot prove that the medication works that way, right? Because a lot of seizures stop on their own. So you don't know whether the drug made it stop. So what they have done is they have benchmarked to see that those, like during a period you could indeed have clusters. What they did to test this, to differentiate from placebo, when they did the rectal gel is to compare what's the likelihood of another seizure occurring. So if you have like a viral infection, or if it's a menstrual thing, it's quite possible that you're going to end up with 2, 3, 4 seizures in the same day. So they could show that if you took this medicine and then observed for anywhere from 6 to 24 hours, what's the recurrence rate, and then say the medicine made a difference. So that's how the FDA approved the medication. So all the products in this domain keep talking about clusters. But most of the time for my patients, the first seizure is not a trivial thing. They don't say, let's wait and see if they have 3 more, right? We really don't do that.
So the severity of the seizure wouldn't, make, you should just use it. If she's, like, my daughter has tonic-clonic seizure.
Yeah, for grand mal seizure, you don't have to wait. You don't have to
just
wait.
use it.
No, you use it.
That's
You don't say, I want to see 3 more.
Because I wasn't sure, should we measure the time if it goes past a certain time, then use it, or?
Well, the time we have historically used, particularly when the rectal gel first came to market, we often told people, give a seizure 5 minutes, right? If it doesn't stop in 5 minutes, use it. Where did that come from is a good question, right? Well, where it came from is a long time ago, one of my very dear friends and colleagues, Professor Shinar, studied a very, very large number of seizures. It mainly applies to children and adolescents, but you can kind of extend it even to older people. What he found is the vast majority of seizures stop on their own in anywhere from 45 seconds to a couple of minutes. What he found is, if you were to plot what is the likelihood that the seizure is going to stop on its own, in that early time, first few minutes, it was very good. It changed very abruptly, very sharply between 5 and 10 minutes, right? So what they found was seizures that have gone past somewhere between 5 and 10 minutes became very unlikely to stop on their own without a specific intervention. Okay? So, how do we modify it to your own child? Now, if it is a focal seizure where they are just kind of staring and there's no grand mal or generalized tonic-clonic, you can certainly wait 3 to 5 minutes. One of the other things we also note is with the rectal gel, there is a finite amount of time to prepare the child or youngster to receive it, right? They're clothed. It's a little bit more time consuming than the nasal spray. The nasal spray takes practically no time. So, another finding that we have known from a long time, particularly in youngsters with febrile convulsions, is those who presented with a long first seizure are very likely to have future seizures that are going to be long. Why is that important? Because if you have a child or a family member that has had prolonged seizures, even though they don't have them frequently, that does predict that maybe you don't need to wait 5 minutes, right? Because you know from previous history that they're not going to stop on their own, right? And the key thing to remember is you get the same class of medication in the emergency room. This class of medication works best when given early. The longer you wait, they usually need a bigger dose. The reason for that is when you keep seizing, the network, the neurons that are involved in seizure protection, they lose the receptors for this medication. They get sucked into the cell and you can't access them. That happens only in the neurons that are participating in the epileptic process, seizure process. So when you compensate for the loss of receptor with the overwhelming dose, there are other neurons that control your respiration, heart rate, they're not seizing, they're in the brain stem. So when you snore them, you stop breathing. Then they have to intubate you, they have to take you to the ICU, right? The ER and the hospital can deal with it, but it's a lot of unnecessary trauma for your patient, right? You could use the rescue therapy at home and put this whole thing out instead of going and waiting in an overcrowded. And then if you go to the waiting room and you're still not going to be processed very fast. These days it can take you a long time after you land in the emergency room before somebody is doing something to your family members. So it's really not the best place to treat these seizure events. Okay? So that's really the value these products bring.
So it can be used even if it's not a convulsion type of a seizure.
It can be,
used
yes.
if you have just a vocal.
It works on all types of seizures.
Okay,
And as I mentioned, you don't have to wait for the seizure to stop. They don't have to inhale. They don't need to participate.
yeah.
Okay. Yeah. Any other questions? So anyway, for me personally, I've been practicing long before any rescue was available. And it was really, really challenging in those days. And then we went through a long period when the uptake of this concept was very low, because once the child gets to a certain age, or if the patient is a young adult, they don't want to talk about rectal medication. Right? If you are traveling with your family member on a flight to Ohio, to the Football Hall of Fame, right? You don't want to be pulling down their pants in the middle of a journey. I think it's a lot easier to carry this and use it. Okay? Anything else? How are we doing with time? It's 11 o'clock. Somebody else actually has the platform to speak. If anybody wants to talk more about rescue, that'll be part of my tomorrow's talk on Ask the Experts. I'm going to be talking about new medications as well as rescue. 10:30 tomorrow in a different room, and that's a 1-hour session. But I'm also not going to talk to you in the hallway, because not out of any disrespect, but I need to deal with this traffic to get to my clinic this afternoon. So if you didn't get to something, or if you think of something later, you can corner me tomorrow. I'll be much more flexible. Okay?
Thank you.
Bye-bye.